Good afternoon, everyone, and welcome back to everyone on the Zoom webinar. I think this morning was fantastic. I thoroughly enjoyed it and I learned a lot. I hope the afternoon will be just as informative for us all. I'm delighted to welcome as our first speaker this afternoon, Professor Robert Thomas from Addenbrooke's and Bedford Hospital, who's a consultant oncologist, but has a really keen interest in diet and lifestyle post-cancer. When we drew up the program for today, he alerted me to the fact that he's actually been working on a fascinating project with long COVID, and which I'll let him explain to you in greater detail.
Right. Thank you very much, Mark. And it's an honor to be speaking in such a topical conference. I mean, it couldn't be more on tune, could it? So yeah, as I say, my day job is an oncologist, but I actually I'm linked to a local university where I've got a chair in lifestyle and nutrition and sport. So it's from that hat I'm speaking, not the oncology hat. So I'm going to talk to you this afternoon about a couple of studies we've been doing involving patients with short and long COVID, called the Phyto-V study, which was published yesterday, in fact. So again, couldn't be more timing. And if anyone wants the paper, I've printed out about 10 and they're on the desk, but I didn't realize there's so many of you, but I can give you the link to download it. It's open access, so you can download it free. So you're all experts in the room. You know what COVID is. It's an RNA virus. It's a tiny strip of RNA, and all that wants to do is just survive. And it survives by infecting millions of people around the world. And we're all familiar with the cough and the breathlessness. And of course, with long COVID, all these really unusual symptoms such as joint pain, GI symptoms, which does occur with other viruses, but of course, long COVID is particularly bad at these. But for a doctor, that's bad enough. But how it affected our medical services was devastating. Half the staff were off sick. All this ridiculous having to isolate for half the year. So we were running on a shoestring. Medical services virtually imploded. We couldn't get chemotherapy going. We couldn't get radiotherapy going. There's no one in pharmacy to dispense the drugs. So, that was the biggest damage, as far as I'm concerned, in the hospital. And it resulted in a lot of delays in treatment, which we're just catching up on. So before we go into things, I'm sure no one in the room is blaming anyone for getting ill or anyone for getting COVID, because anyone can catch it. But there's clearly a difference in how you react to COVID by who you are and your other problems. So if you're a fit under 50 woman with no other comorbidities, the chances of dying of COVID is less than sort of 1 in 10,000 probably. We just put a conservative estimate of 0.001%. However, if you're a man, men are more susceptible to COVID. Interestingly, when you take a man's testosterone away, they have a better protection for COVID. So it is a real thing, because if you give them Zoladex, so this has been looked at because I give Zoladex to men to castrate them for prostate cancer, and everyone said, oh, they've now got on chemo drugs, you have to protect them. But someone did a trial of that and actually have more protection. So it is true, women are better at defending against viruses, not a myth. So if you're an old man, if you have comorbidities, then it is a very serious illness, as we all know. So this is data from the Worldometer, which shows, the older you are, in fact, if you're over 80, as a rule, you have almost a 14% chance of dying if you have COVID. This was, back in April last year. And why is that? As we know, when we get older, we have reduced gut health, our immune surveillance diminishes, and we have excess chronic or inappropriate inflammation. So we're more likely to catch the virus, and we have an inappropriate response against it, usually an excess response with reduced oxidative pathway. And of course, we're more likely to have comorbidities. So if we do get the virus and you've got heart problems, you're more likely to die of a heart problem. However, there's data coming out from China, which I'm familiar with. But if you looked at people over 80 who didn't have comorbidities, in other words, fit 80-year-olds, actually the chance of dying is significantly lower. So it's probably the correlation with illness rather than age itself. So don't worry if you are older, if you're fit, it still protects you. So what are the comorbidities which have been published to increase your risk? Well, diabetes, obesity, central vascular disease, cancer, hypertension. And the more comorbidities you have, the more chance you are of dying. So if you have one, it's bad. If you have two, if you have three. Now, interestingly, in the good data from New York, which was published last May, they recorded the demographics of the patients in they had a sudden urge of COVID. I don't know if you can remember that. I mean, literally, the whole of New York caught it over about a month, but they recorded all the data, and there was nearly 16,000 very unfortunate deaths, which occurred quite quickly. Only 99 of those deaths did they not have any comorbidities. So, comorbidities are very important. So if you didn't have a comorbidity, the chance of dying, again, is very small. But the problem is there's a lot of people with comorbidities, particularly in New York. So, a lot of people are overweight. 70% of the population in Britain and America, we can't just point a finger at America, are either overweight or obese. I'm sure you know all these facts. And it's getting worse. I mean, this is the incidence of diabetes over the years, linked to sedentary lifestyle, being overweight, sugar intake, etc. I mean, it's almost doubling every 20 years. I mean, this is a pandemic, diabetes. Obesity, well, being overweight doesn't seem to have changed much, but being obese is going up considerably. And this is a frightening figure. The extremely fat, really big, morbidly obese, who have feeders giving them Kentucky Fried Chicken 3 times a day, those are going up significantly. I mean, that's 10% of the population in America. I mean, can you believe it? And that's the vulnerable group. So the trouble is with the patients I see, you're an educated audience, you're a nutritionist, so you know all this, but the average patients we see, in Bedford and Cambridge remain very confused what they read on the internet and what they've been told about how to improve their lifestyle. Many of them don't have the luxury of coming to a nutritionist, which they of course should. So what we've done in our lifestyle unit, where we were doing previous research on cancer, is we thought, well, as we had to stop all cancer studies at the start of the pandemic, we moved over to trying to help the COVID fight. And this is what we do. We do evidence surveys looking at the international literature. We ask patients about behavioral change and what's stopping them changing, etc., and their habits. And ultimately, we design double-blind randomized trials, which is the gold standard of research. And what we do with this data, well, we publish it in medical journals, which is occasionally read. But we try to reach out to more relevant journals. So if we did a study, for example, on cycling and prostate cancer, we actually published it in Cycling Weekly rather than a medical journal where it's relevant to the readers. And then we give information to a lot of the main charities and have our own blog. So if, for example, someone asks us a question about high-dose vitamin C, should I be having it? We'll do an evidence review and put it on the blog, and they can read it for themselves and make their own decisions. And just going to show off about my book there. So I write a book every few years as well. So these are some of the things we've been doing. This was a study, before I go into the COVID, just as a bit of a background, this is a study where we looked at nutrition and prostate cancer to see if there was any evidence that putting concentrating foods and supplements could slow the rate of prostate cancer, because there were some small anecdotal studies looking at extracts and things. So this was a government-backed study run by the NCRN, National Cancer Research Network. And after 18 months of sort of searching, a capsule was formulated with whole foods, consist of pomegranate, green tea, broccoli, and turmeric. And we did a double-blind randomized trial, and it showed a significant slowing down of PSA progression, which means a lot in men with slow-growing prostate cancer, because that would maybe stop many of them going on to needing radiotherapy or surgery. And that was actually published in ASCO, which is the world's largest cancer conference, as a plenary session. So it's in front of 44,000 people. So the message there is, if you do nutritional studies, they are taken seriously by the medical professions and given the platform. So it's not that they're against nutrition. A lot of nutritional studies aren't very well conducted. That's the issue. This supplement, unknown to ourselves, was then investigated in Japan. And it was just a small study where they looked at people with menopausal symptoms, particularly joint pains, and they showed that there was a small but significant benefit. So helping about 13% of people with joint pains, particularly after breast cancer and other cancers. And probably, it makes sense because it's got turmeric and all the tea and healthy things, which we know help these symptoms. So coming now on to gut health is what we're going to lead on to the COVID story. We all know that if we have poor gut health, we're more likely to get indigestion, be on antacids, have bloating, intermittent diarrhea and constipation, which is a familiar side effect or symptom for many of us at times. many people are just living with these symptoms all the time. And the underlying mechanisms, and I'm sure you all know this, so apologies if I'm speaking to the converted, is that with chronic poor gut health, you get inflammation of the lining of the gut. You open up the gaps between the gut cells, which leaks out nutrients into the feces, and more importantly, it leaks toxins which were previously not absorbed into the bloodstream. Your body issues an inflammatory response against these toxins, and then it's using up the inflammatory pathway, so that you become immune deficient, but at the same time, you're triggering this chronic inflammatory response. And as a side line for this chronic inflammation, these antibodies then attack our own body. And in fact, the latest theory for type 1 diabetes is you have poor gut health as a child, and when the collateral damage to the body trying to attack these toxins is it actually attacks the pancreas at the same time and kills it, and then you've got diabetes. That's sort of yet to be absolutely proven, but that's a very strong theory and it makes perfect sense. But of course, it attacks other things like the brain and things. But for oncology, now gut health is actually really, really important. So people like yourself and I've been banging on about gut health for 20 years and they've just been laughing at us and say, yeah, you're just joking. Now, these drugs, they're called PD-L1 inhibitors, which we're all moving on to in oncology. They're £100,000 a year, but they're very, very successful. They uncloak the cancer cell from the immunity. So the cancer cells are very good at hiding from the immunity. But what these do is they uncloak them, a bit like the invisibility cloak in Harry Potter, and the immunity can see them and it kills them. So it's using the own body to fight cancer, but giving it a head start. And they are very expensive. Now, someone in Andy Anderson, in Texas, found out that if you have poor gut health, you have a 40% less chance of responding to these drugs. Makes sense because you're using your own immunity to fight it. So if your own immunity is running at half-mast, it's not going to fight it as well. Plus, if you have poor chronic inflammation, you get much higher toxicity. You're more likely to get pulmonary toxicity, joint problems, and end up in ITU after you've given them. So it's now all the attention's moving to gut health from when it's previously been ignored for the whole of mankind. And now they want to do prehabilitation programs to get gut health up and running before you have these to prevent you ending up in ITU and getting a better response. And there's even whole departments in Cambridge converted called the Gut Signature Project, and they're getting enormous funding from drug companies now. Surprise, surprise, because if they're selling a drug for £100,000 a year and they get a 40% increased response rate, you do the math. So that's a good way of getting funding. So if you've got any projects in gut health, go for that. So we know that poor gut health leads to a lot of problems, in the long term, more likely to have ulcers, food intolerance, bowel cancer, allergies, etc. We're also familiar with the gut-brain pathway, more likely to get low mood, depression, dementia, and then in the long-term neurodegenerative problems such as Parkinson's disease, Alzheimer's, etc. So this is, you're all familiar with that. But since COVID, we've been doing a lot of work and realizing that actually there's a gut-lung pathway, which is just as prominent, but not as well talked about. And it is well known now, or there's lots of publications showing if you have poor gut health, you're more likely to get asthma, colds, viral infections. And if you have a viral infection, you're more likely to get ARDS, which actually kills you. So, and again, this has largely been ignored. And in fact, if you look at people with ARDS, adult respiratory tract syndrome, you actually find pro-inflammatory bacteria or bad bacteria, which has gone through the bloodstream, which has leaked in through the leaky gut, so it shouldn't normally leak into the bloodstream. And they actually find it in the respiratory tract and within the lung itself. And those pro-inflammatory bacteria are then leading to this excess inflammation or the cytokine storm, which is fatal and looks like that. And this is actually one of my first patients who actually died in December 2019. And before we even knew it was COVID, we only found out 3 months later. When we were, we've unfortunately had at least 50 patients who have had to care for who have died of COVID. So no one's dismissing the seriousness of COVID. An interesting story, I actually wore a mask when I attended that patient. I was told off by the hospital for wearing a mask when it wasn't hospital policies. Now you get told off if you don't wear one on a train. So anyway, and she was coughing all over us. So Anyway, that's the way the world is. So what do we know about gut health and COVID so far from the trials which have been published over the last 18 months? Well, we know that the majority of patients, when you analyze their stool, have a pro-inflammatory picture, so a poor gut health. In other words, they have depleted lactobacillus, particularly. We know that if you have the GI symptoms, you're more likely to get that dysbiosis, which makes sense. We also know if you have dysbiosis and gut symptoms, you're more likely to get the non-respiratory symptoms. So you're more likely to get worse respiratory symptoms, but also more other symptoms, such as, you can't smell, or headaches, or fatigue, and those sort of things. So it does seem to be, very much linked to a more severe disease and a more general disease. And these have all been published in good journals since the start of COVID. Now, you know more than me about how to improve your gut health, so please, I'm just giving you my perspective, so you can shout me down and say I've got it all wrong. But this is my simple doctor's interpretation of how we can improve gut health. And it's not just about the food. It's, of course, we know that eating processed sugar feeds the pro-inflammatory bacteria, eating too much meat, having poor dental hygiene, not exercising, being stressed, and smoking. These all influence your gut. So it's not just about the food, but of course food is important as well, both in terms of the prebiotics and the probiotic foods, such as kimchi, sauerkraut, and things. I'm still not sure about whether food with bacteria needs to be alive, and I'll pick your brains later, because a lot of sauerkraut is pasteurized with this, and lots of sourdough bread is pasteurized, but anyway, it's cooked, so you can inform me later. But anyway, people tend to ignore, doctors tend to ignore the prebiotics, which I believe is just as important as the actual probiotics, and also forget that although fermentable soluble fibers are important, like inulin, starches, etc., and these are a lot of things added to supplements, it's actually the prebiotic polyphenols are very, very important. Polyphenols are the things in food, as you know, which give it its color, its smell, and its taste, and has numerous health properties. But these things are very, very powerful prebiotics. They don't work as fibers, though. They just help feed the healthy bacteria, and they help to form, butyrate and things which help gut integrity. And we know that they also, some of these prebiotics have antibiotic properties which actually kill the pro-inflammatory bacteria, but not the anti-inflammatory bacteria. And they stop adhesion to some of the poor unhealthy bacteria. So they give more room for the healthy bacteria to grow. So there's lots of good mechanisms why they're important. Should we be putting them in supplements? And I'd like to just go on the rest of the talk about this. Well, first of all, is there any evidence for taking probiotic supplements? Well, there is. I haven't listed all the references, but certainly after antibiotics, after chemotherapy, radiotherapy, if you've been taking a non-steroidal anti-inflammatory, traveling to different countries, going into hospitals. Some hospitals are actually advocating taking probiotics before admission, as it reduces the incidence of superbug infection after an alcoholic binge, or if you have symptoms. So there are evidence that they could help, and I'm sure there's more, and you can tell me more about that. Is there any evidence they help against flu or colds? Well, there's a lot of studies, including some double-blind randomized trials which have taken place, giving cohorts probiotics and recording the incidence of symptomatic viral infections. And there's quite a few show that they do. So if you've got a vulnerable group and you give them probiotics, you're less likely to get a cold. This was I don't know if anyone's familiar with the King's App Fund. I think it's got another name, where they looked at 500,000 people during the pandemic and looked at the intake of different supplements, as well as lots of other things, and recorded the subsequent development of COVID. And they published last year, and they showed that people in the population who'd signed up to the app, if you took vitamin D or probiotics, you had a lower chance of catching COVID. So it was the first time there's a bit of an inclination there. And then since then, there's been numerous studies across the world looking at probiotics and various things to see if it would influence catching COVID or things after COVID. Could you put polyphenol-rich foods or prebiotic-rich foods into a pill? Well, we know that these polyphenols, I've said, they have prebiotic elements, but actually they're very, very, very healthy in many other ways. We know that they can help to switch off excess inappropriate inflammation, but they don't dampen down appropriate inflammation. They actually can help epigenetic expression of the genes we're born with. So our unhealthy genes can be suppressed, and they enhance the suppressor genes which as well. They slow down the import of sugar across the absorption of sugar across the gut. So that's one of the reasons why fruit is very, very healthy, yet processed sugar isn't, because it's actually slowing down the sugar transport, reducing the glycemic index of foods. They have some direct anti-cancer properties. They help DNA repair, and they enhance antioxidant enzyme performance. Many people call them direct antioxidants. As you know, they used to be called that, didn't they? But they're not actually. Direct antioxidants are vitamin A and vitamin E, as you know. But most of these sort of foods, they actually enhance the antioxidant process. They encourage the antioxidant enzymes to upregulate when they're needed, but they also help to switch them off when they're not needed. So they prevent antioxidant stress. So they're not, they said you shouldn't be calling these antioxidants. But these foods actually, through the last SARS epidemic and previous studies, have been shown to have direct antiviral properties. So not only they could help someone with COVID because they're reducing the excess inflammation, which is ultimately fatal, but they could, in theory, reduce the viral attachment to cells, reduce the penetration of the virus into cells, stop the proliferation within the cell, and ultimately shedding. And there's lots and lots of data to show that. They're mainly in animal studies, though. So the number of human studies is quite limited. And the foods which seem to have the best publication related to them really are these sort of foods. So things like citrus bioflavones, chamomile. Someone came up with the theory that Germans had less COVID because they had a lot of chamomile tea. I think that's a bit of a step too far, but it is interesting. And they subsequently got it anyway after and the pomegranate, quercetin, all these things have been found in animal and cell line studies to have direct antiviral properties. But those are animal studies. But nevertheless, after that background, a lot of studies now are going on around the world to try and see if we could enhance the diet with these foods, usually with supplements, to help COVID. So which brings us on to our study. We called it this is what it was. It's a double-blind randomized control trial analyzing the influence of phytochemical-rich foods and probiotics in people who've caught COVID. We have to thank Captain Tom, who unfortunately passed away in our hospital, so it's not an advert, but his appeal, some of his money went into our study, which is good. We have to thank a lot of the scientific committee, which actually was from universities across Britain, but also manufacturers of supplements who are actually very, very well knowledgeable in this field. I know I won't go through all the background, but there was a sort of 4-month scientific evaluation of which studies had the most benefit, and it was the lactobacillus had the most benefit. That's not to say other probiotic bacteria couldn't benefit as well, and they probably do, but that's where the evidence lay for viruses in the past. Plus the ethical committee, who we had to submit the trial to 3 times, I have to say, were very concerned about probiotics with lots of different bacteria where they wanted a single strain because it was easier scientifically to evaluate. So anyway, I'm not saying that couldn't be improved, but that's what we ended up choosing. So these bacteria all had some evidence of protection against viruses. Obviously, we made sure it had plenty of prebiotic inulin in it and a delayed release capsule and a reasonable concentration. So it was called Your Gut Plus, which is called now, but obviously it was double-blind randomizing, so all the packaging didn't have any branding on it. And this was the supplement made with the foods I just mentioned, with the advice of the companies who make them. So what were the primary endpoints? We looked at fatigue, malaise, cough, subjective well-being, and gut symptoms measured by formulated toxicity questionnaires. And we wanted people who had acute COVID, because when we started the trial in May 2020, there was only acute COVID, but we fortunately did have a clause that we could include post-COVID. And in fact, most of the patients in the end were post-COVID. And this was what it looked like. It was just a double-blind randomized trial. If you had your COVID, you were initially we randomized the probiotic, but we had to stop that and do a protocol amendment because too many people were taking their own probiotics. So we ended up giving the probiotic to both arms and then just randomized the phytochemical complex. And this is so we had 159 patients. It turned out that 75 or 75% actually had long COVID, with the overall duration of symptoms before trial entry was 118 days. But of course, in that group, it was more like 130 days. And it was fairly evenly mixed. What we did learn is the number of symptoms people presented with, and I'm sure you're familiar with that. It wasn't just they were getting a temperature or a cough. There was a whole load of things from, perspiration, hair loss, dizziness, peripheral neuropathy, rashes. So there's a big spectrum of symptoms people report, which they didn't have before they got their COVID. And we found, first thing we found, which was in agreement with other studies, that people with GI symptoms had worse symptoms, but we knew that already, but we're just confirming that that was the case. So we published it in 2 cohorts. Because the probiotics were given effectively prospectively to all patients, we published this separately, looking at the change in symptoms over the 30-day intervention. Now, obviously, for the acute COVID patients, that would have been expected because the duration of symptoms is usually 14 days, so most people would have got better anyway, and we showed that, but that is probably not that relevant. What was relevant is these patients, the 75% of patients who had symptoms for over 120 days. And in that group, there was a very rapid and significant improvement, both in cough, fatigue, and overall quality of life. And that was highly statistically significant. And I think that's very clinically relevant. So this intervention did help those people. And who did it help more? Well, interestingly, it helped more the people who you would expect to have poor gut health, which isn't a surprise because it's an intervention to improve gut health. So males, older patients, people who'd been hospitalized, because at the time the policy for hospitalization is they get given steroids and antibiotics. Both those things can upset your gut health. And people with a prior history of indigestion or indigestion at baseline, or those who did little exercise, those are the people who had the best benefit from the probiotics, because probably they had the worst gut health at the start. And then when we looked at that, then the other element of the study was placebo versus the phytochemical supplement on top of the COVID. And there was a very highly significant further improvement in that group. So the group which took it had almost, well, if you want to do percentage, almost double the reduction in those symptoms. So in summary, we know that having GI symptoms correlates with worse outcomes. We felt in the long COVID that the lactobacillus insulin blend did improve symptoms, not just cough, but fatigue and overall well-being. There was actually a greater benefit to probiotics if you had those vulnerable groups. And on top of that, the phytoestrogen complex, not phytoestrogen, the phytochemical complex further improved your well-being. Since we published, well, that's been published in 2 quoted. There's been 2 other papers published. I don't know if you're aware of that. One from, I don't know where that's from. I think it's Germany. And one from Mexico, and one from North Carolina, which almost did an identical study. And it's always nice as a research to know that there's people doing the same things as you, and you're not completely out on a limb. And they also just used lactobacillus, which is also interesting because none of us talk to each other. And they also showed that they helped. So there's now 3 studies, including our own. So that's reassuring that there are other published studies out there showing benefits for lactobacillus. What are we doing now? We're moving on to a vaccine study because we know that if you have higher titers after a vaccination, you're more likely to have protection from what you're vaccinating against, which is pretty obvious. We know that you're more likely to get better titers if you're a woman, younger, not obese, and if you previously had COVID, which again is pretty obvious. The problem is the vaccine isn't that successful. Well, it is successful, of course, but it's not successful in anyone. And a lot of people are getting COVID after the vaccination because the immunity is wearing off quite quick. So what can we do to improve the longevity or the effectiveness of the vaccine? Just 1 minute. So one thing is to make sure your vitamin D levels are good, because we know that if you have low vitamin D, you don't respond to a vaccine as well. We also know that if you exercise, you're more likely to get better titers afterwards. And we also know from, this is a meta-analysis of lots and lots of studies which have given probiotics before a vaccination or not. And there was a very significant trend that probiotics do improve antibody titers after the vaccine. But this was all for flu vaccine, not COVID, right? So you can't say it helps with COVID. So what we've done is saying, well, we know there's evidence for flu. Let's do a trial where we give people either a placebo or a probiotic at the same time as the vaccine. We then encourage them to exercise, measure exercise levels, and we've got Roche to sponsor us to measure antibody levels to see if that intervention will improve antibody titers, and also whether those antibody titers would last longer, and ultimately whether it would protect them from COVID as well. So that's all I've got to say. I'm over time because Mark's jumping up and down there. So there's questions at the end, I understand. Thank you for listening.